My name is Ambika Kapil, and I'm a third-year medical student at Nova Southeastern University. And today I will be presenting my poster titled Navigating the Clinical Challenges of a Sotalol Overdose. Here we see a suicide attempt that manifested as a ventricular tachycardia, asystole, and torsades de pointes. And this is a really interesting case because it really allows us to delve into the management of a beta blocker overdose, which involved prompt intervention to stabilize cardiac function as well as to prevent further fatal outcomes. So here we had a 59-year-old female with a history of anxiety who presented to the emergency room after ingesting 15 Sotalol tablets, so in total 120 milligrams, as well as 3 acetaminophen tablets. Previously, the patient was said to be exhibiting paranoid thoughts and disorganized behavior, as described by her husband, but in the hospital, she denied any chest pain, palpitations, shortness of breath, vomiting, or diarrhea. On admission, her blood pressure was 128/76, her pulse was 59 beats per minute, her respiratory rate was 17 breaths per minute, and overall, she just seemed a little bit frantic and worried given her ingestion in the previous few hours. However, within hours of being in the hospital, she developed acute hypotension, a blood pressure of about 57/32, and bradycardia, 52 beats per minute. And this all prompted the activation of a rapid response team approach. Initial physical exam was unremarkable, except for the anxiety and the sad appearance, and her labs showed a BUN of 23 milligrams per deciliter, an elevated BUN creatinine ratio, and a urine creatinine of 324.8 micromolar per liter. Through the urine drug screening, overall, though, was negative. Her EKG did reveal frequent premature ventricular contractions and nonspecific ST wave changes. And her chest x-ray was normal, and a POCUS that was done showed a left ventricular ejection fraction of about 55 to 60% with mild mitral and tricuspid regurgitation. Also, the CT brain showed no acute intracranial events. Overall, the patient was admitted to the ICU for her beta blocker intoxication, her hypotension, bradycardia, and suicidal ideation. Initially, we managed using IV calcium gluconate, glucagon, atropine, dopamine for the hypotension, and amiodarone for her arrhythmias. She progressed to a code blue on ICU day 2 due to the asystole and torsades de pointes, which ultimately required electrical cardioversion and continued management with the amiodarone and the magnesium. We ultimately also had to do hemodialysis on day 2 for her acute renal failure, but by day 5, she was started on a psychotropic medication, then venlafaxine and trazodone, and transferred to the psych facility on day 7. She was overall advised for indefinite Sotalol contraindication and further encouraged to keep in touch with her psychiatry notes to ensure that she was getting the care she needed so nothing like this would happen again. Overall, this case highlighted the importance of having a multidisciplinary management approach and treating a cause for hospitalization and an overall underlying psychiatric condition of a patient. Thank you so much for your time, and please feel free to reach out if you have any questions. Thank you.